So welcome back to another episode of Myths, Misconceptions and Misunderstandings of EDS and HSD. So I hope you've been enjoying this series. I'm getting lots and lots of feedback and comments, so thank you for that. So today's a little different. You'll notice I have a guest joining me, who I'll introduce in a second. But today we are talking about nutrition. And myths and maybe misconceptions or simple misunderstandings that are out there and out and about in our community relating to nutrition and diet. So I thought I would speak to the leading EDS clinician in this area, and some of you may know her. Her name is Lorna Ryan. So thank you for joining me, Lorna.
Oh, it's my absolute pleasure, Jeannie. Thank you for inviting me to talk about the lovely myths we have.
Yes. And I've been covering all the myths there are around movement and diagnosis and pain and psychology, which I see a lot of, obviously, in my clinic. But I also do hear these myths about nutrition. And I think on social media now, there is an awful lot of information out there on nutrition. And it's hard, really, to decipher what's correct, what should I be doing. And I think it's really important, obviously, that people do see a properly qualified either nutritionist or dietitian if they are considering any changes to their diet. I think that's really important that we kind of say that. But yes, so yeah, these are some of the myths that I've heard, that my patients have mentioned to me. I know you've heard some of them. And as I say, social media, there's lots of info out there, and we're just going to try and decipher, where are these myths coming from? Are they true? Are they misunderstandings? So hopefully you'll enjoy this. And so Lorna, just before we get started, you're also the lead clinician, aren't you, on the EDS Society Consortium for Nutrition and Diet? That's right, isn't it?
That's right. So I chair the Diet and Nutrition Working Group, and there's a small but perfectly formed team of experts sitting across the different specialties within nutrition and dietetics.
Fantastic. Brilliant. Well, really great to have you here, and thank you for your time in helping with dispelling some of these myths. So the first one, and I hear this a lot, and it's kind of a big overarching one. Is there an EDS diet? Should I be doing, someone with HEDS and MCAS and POTS, can I do an EDS diet? Is there an EDS diet I should be following?
Yeah, and this is a really, really good one to kick off with, isn't it, Jeannie? Because if you just Google or go onto any social media platform, you will see an EDS diet, and it will be glossy and it will look wonderful. And we really have to acknowledge that the patient population at home just want to feel better. So they may be like, this is super, this is very attractive. But no, we don't have one. So there is no one diet to support EDS. And the other important thing there is EDS is just not a good term anyway, because what type are you? Hypermobile EDS, classical EDS, even vascular EDS. We have our big umbrella of subtypes. So if you do see a sort of lovely pot of gold of one diet's going to fix all of your EDS issues, just as a sort of consumer of, if you like, media, step back and say, well, does this talk to me? And what type of EDS do you have? What are your comorbidities? And the reason we can't say that we have an EDS diet is because we haven't got any robust literature and studies. So the dietary plans, if you like, haven't been tested in a robust medical dietetic situation to prove an outcome. And secondly, no one person with EDS, even if you've got HEDS, no one person's the same, and no one person has the same starting point of diet anyway. So categorically, very blankly, very black and white, we do not have one EDS diet, no. But this does not stop us being able to say that diet is very important in managing symptoms.
Yeah, that's perfectly explained. Thank you. Yeah, so research, obviously, hugely important, which we don't have. And absolutely, everyone is different. So I don't think that in that case, then, I doubt there will ever be one EDS diet, will there? There'll be lots of different variations to suit different people.
Yeah, exactly. And we're working really hard on building consensus of potentially what dietary interventions might have better health outcomes. But I doubt we'll ever get to one consensus international of this is the diet for EDS, like you might have for, say, type 1 diabetes or for cardiovascular disease, because there's just far too many sort of nuts and bolts for people.
Yeah, very interesting. So I think that's the sort of the big overarching sort of myth out there. But I'd like to go sort of a little bit more into the detail and a few sort of other myths around. Do you need to reduce fiber intake? Why would people be saying that it's important to reduce fiber intake?
So I hear this a lot, both just on the sort of the vast social media platforms, Google, but also people coming to clinic have already been hearing this myth. There's a lot of forums where people discuss you should reduce fiber because of GI symptoms. So if you have gastroparesis or slow motility or constipation, which we have to be mindful that constipation is also a medical condition for different gastrointestinal reasons. So the myth is reduce fiber. The reality is fiber isn't one thing. So we actually have 3 different types of fiber. So the myth is reduce fiber to manage GI symptoms. But where this is mistranslated, perhaps in the comprehension, is that fiber is actually very, very beneficial for gastrointestinal function for general population as well as EDS. So how that translates to reality is if you have a gastroparesis diet, people will say in their sort of like myth world, reduce fiber to help your symptoms. But clinically, what we might say is we want to pay attention to the type of fiber. So we have insoluble fiber, which doesn't dissolve in water and attracts bulk to the stool. And then we have soluble fiber, which does dissolve in water and it attracts water, turns to a gel. And they both have very different ways they support the gastrointestinal tract, gut flora. So we can manipulate fiber types. We might want to wind down soluble and increase insoluble. We might want to sort of manipulate prebiotics, as in prebiotic fibers, but we never want to reduce overall fiber intake unless we're needing to manage someone individually. So what that looks like, and this is why these myths never work, is if someone was to come to clinic with slow motility and constipation or sort of quite out of control diarrhea, we might want to reduce fiber to work on a few gastrointestinal functions and then build it back up. So when I hear these myths of reduce fiber, I'm like, no, because fiber is so important. And we actually know that fiber overall, both insoluble and soluble, they really are important for motility in that gut-brain axis. So reducing fiber, no, it's a myth, but manipulation and type of fiber is key to understand for the individual.
Fantastic answer. So there you go. We're putting that in the myth bucket. That is a myth. And a very complex subject by the sounds of it. All different types of fiber. So yeah, it's not just black and white, is it? Very interesting. So what about, I hear this a lot actually, and a lot of my clients do, and I know it does work for some people, this go gluten-free. You need to go gluten-free if you've got EDS. What do we think about that myth?
Well, I hear it a lot. And, you know, I really want to acknowledge that how some people do have a lived experience of feeling better when they remove gluten from the diet. But that does not equate to gluten being the problem or the devil or the thing that we have to restrict. So we do observe people have removed gluten out of the diet, and some of their symptoms, which may be gastrointestinal, motility, for example, bloating, fatigue, pain, headaches, do improve. But then we look at why it might have improved. And quite often, if we're going to take gluten out of the diet, gluten, for clarity, is found in your wheat, barley, rye, spelt, and it's bound up in a lot of processed food. So quite often, if I was to take a really thorough dietary history from my new intake of patients, and we ask questions around when they started to eliminate gluten foods, they're actually eliminating processed foods as well. They're also naturally reducing some of the foods that sit in the FODMAP group, which are known to potentially ferment and cause a few symptoms. And so we're actually just taking something out and believing that's what's improved our symptoms. And it's not necessarily that it's a blanket myth, because yes, people do improve, but we have to look at why. And this is where the misconception comes into place. So it's either that maybe through one reason or another, reducing fibre is actually one of them. You're no longer to break down the proteins of gluten that well. You may also have some intestinal barrier issues. People sort of clone this as leaky gut, which I'm not a fan of, but this is what people might relate to hearing. And therefore, from an immune reaction side, people might be reacting to the proteins in gluten. But from clinically, what we don't want to see people do is just to blanket take gluten out of the diet, because we want to ensure people are not celiac, and we do have a higher prevalence in our EDS population. We also want to make sure that they are not having an immune-mediated reaction to gluten, which is known as gluten sensitivity. So actually, we want to have the dialogue about, is gluten maybe a negative thing for you in the diet? But we want to then investigate that further and maybe get you to some really appropriate testing for gluten, either celiac disease or gluten sensitivity. And then we know where we are and we can help you dietary wise from there. So although it's not a blanket, this is the wrong thing to do, it just takes a little bit more evaluation to see if that's the right thing for somebody. And on that, because it's again another huge topic we could do a day on, if someone does feel better on a gluten-free diet or does need to take gluten out of the diet, we have to make sure that we're putting nutrients back in, because a lot of the gluten-containing foods are our fibres, our iron-rich food, our B group vitamin-rich food. So it's not as simple as take it out and you'll be fine. We want to make sure everyone's replacing with something.
Fabulous. So yeah, maybe this one then is a misconception as opposed to a total myth.
Right.
But again, it's a very, very complex thing, isn't it? I think sometimes, I mean, I'm not a nutritionist, but I do see things, and I think it's presented in a very simplistic way on a lot of the social medias. And from what you're saying, clearly there's a lot of thought and processing that has to go on when you're evaluating somebody. It can't be just black and white. So yeah, it's fascinating. There's a lot of intricacies, isn't there, into evaluating what's right for each person.
There really is. That's spot on, Jeannie. Yeah.
So this one, again, I know a few people who do it. I don't really know what it is, so I'd love to know. A keto diet. So again, this is another one. You should try keto. Yeah, what is that and what does it involve, and is it true?
Well, again, many layers. So a keto diet is a ketogenic diet where you're actually trying to get your body into ketosis, which means that you're using fats for fuel instead of glucose, which is our normal metabolic state. Now, it's very important to relay to your listeners that the ketogenic diet is a medical diet, and it's actually been proven as a medical intervention for children with epilepsy, and it's also being used, and I'm not going to talk on this, but some areas of, say, brain cancers, etc. For general population outside those sort of medical disease states, we aren't a fan. And the reason being is that to follow a ketogenic diet, you're aiming on being very low carbohydrate, which is also taking out your fibers, and consuming a high fat diet. And it's off the top of my head, and I might be inaccurate on this, but around 20 to 50 grams of your carbohydrates is permitted. And to put that into context, something like a banana is already 27 grams of carbohydrates. So you can see in relation that it's a very, very low carb diet. There's many risks of following this dietary intervention. There's obviously nutrient deficiencies, because in reducing those carbohydrates, you're also reducing the wonderful carbohydrate and fibre rich foods with all of those nutrients bound up in the food matrix. And potentially you may tip into, and not to scare anyone that might already be following a keto diet, but you may tip into liver issues, kidney issues. You might actually get worsening constipation or mood swings, which are two of the things that if you were to Google and go on social media, people say keto diet's good for. So it really isn't validated to be used for general population outside these medical situations. And actually, it's really hard to follow. I hear a lot of people come to clinic and they're like, I've been following a keto diet. You've still got the symptoms and you're probably not in ketosis. Sorry, I'm not good at pronouncing it. It's actually very, very hard to get into ketosis, and you'd be measuring that in ketones in your urine. So for our EDS population, we absolutely have no clinical evidence that it helps. Some people that are maybe pushing on that weight loss side of wanting to manage weight, they might find benefit, and that's literally because you're reducing your food intake because there's not much to eat. It's hard to follow. I wouldn't like to say people are inaccurate by their lived experience of feeling better, but again, it goes back to restricting any types of foods. You're actually taking out a lot of processed foods as well, and probably eating less in general. So no, an absolute myth when it comes to our EDS population. And if someone is playing around with following keto diet, I'd really like to emphasize the potential risks. And if you really you have a bias there and you really want to try it, do tag up with a clinical nutritionist or dietitian to make sure that you're not going to give yourself any negative effects of following the diet.
Thank you. Yeah, very important.
Yeah.
Thank you for explaining that. So what else have we got in our myth bucket? We've got, magnesium. Should we be taking magnesium? Now, I do hear this a lot, actually, and I tried taking magnesium as well, although I didn't see any change at all in my symptoms. But yeah, I'm curious about this, magnesium for EDS.
Yeah, I hear it a lot, and nearly everyone that comes for a new patient in my clinic and my colleagues' clinics are probably supplementing magnesium, because not only is it one of the things that's out there a lot in social media, Google, and even if you do look on really reputable sites for dietary advice, magnesium's kind of the supplement to have. I wouldn't put it in the myth bucket. I'd put it in the maybe misunderstood bucket, because magnesium is actually essential for over 300 biochemical functions in the body, everything from metabolic to digestion to brain function. So where the misunderstanding comes is what magnesium is. And when people look to supplement, I hear this a lot of like, you should supplement with magnesium. And even some medical doctors tell patients this. Well, there's 11 types of supplemental magnesium. The common ones that people tend to know of are the citrates, glycinate, L-theanate, which I probably said wrong, chloride, malate, etc. We can get a really abundant amount of magnesium from our diet. But where it overlaps to our EDS population is that for one reason or another, dietary intake might be a little bit hampered by physically not being able to get the foods in, or already following a little bit more of a restrictive diet, or poor gastrointestinal absorption of the magnesium from diet. So I'm not opposed to magnesium supplementation, and I do use it a lot in clinic. But the misunderstanding of we should take is quite inaccurate. It's not that we should take it every day. It's something to have in the toolbox, and picking the type according to the reason is key. For instance, if you have diarrhea already, you do not want to be having your citrate, which is a natural laxative, because you're not going to leave the bathroom, and you also might get some really abdominal cramps and sharp pains. We know some magnesiums are better absorbed than others. So if we know that you have poor intestinal absorption, we might push you towards like the chloride sides, sorry, my pronunciation's awful, Jeannie. glycinate. um, And then people say you should take magnesium to calm and for brain function. Well, this is specifically where research sits anyway, the L-theanate, because this is going to be helping the more cognitive. But actually the research there is not on humans, and it's very much for the cognitive diseases like Alzheimer's. So when it comes to our EDS population, potentially magnesium might help one of your symptoms. Fatigue is going to be a different type of magnesium to gastrointestinal issues, which is different to muscle pain, which is different to sleep. So what is key is looking at your diet. If you're having animal-based products and lots of leafy green vegetables and legumes and nuts, then we can look at how you can better absorb your magnesium from these foods. Then we can look at what supplement's going to be potentially useful for you. And then it's dose and preparation dependent. So there's many layers to get to the conclusion of what's right for the individual, and having a sort of, what I like to say to people is your range of magnesium. No day is going to be the same. So it's like your little toolkit of, oh, I'm a little bit more constipated today, I'll have a bit of citrate, or I'm not sleeping, so I'll have a little bit of glycinate, and use it. So I think we'll put it in the misunderstood, not myth bucket.
Yeah, no, very interesting. Thank you. Now, this is a question I get asked an awful lot, and I think I am giving the right answer, but I'm going to check with you. Should we be taking collagen supplements? Is that going to help? Is it going to fix our collagen? I think people think taking collagen is going to help with the tensile strength, improving the structure of the collagen. Is that going to help?
Yeah, this is one of the questions I get asked to comment on a lot from patients, clinicians, people just interested. We do not have literature for general population, let alone EDS, that proves collagen supplementation helps collagen in the body. So that's the first thing to put out there. Regarding all types of EDS and also hypermobile spectrum disorders, I see so many people spending, or dare I say wasting, a lot of money on very fancy pants supplements of collagen because the marketing is really good. And when you really dig into the research behind some of these formulations, it's not robust for humans. And also in EDS, we totally understand, and I'm very sensitive to people believing that taking a collagen supplement is actually going to help their own collagen and maybe make more collagen or stronger collagen. So let's break down what the supplement is going to do. If you're not able to assimilate and use it via the gastrointestinal tract, you will be peeing or pooing it out. So quite likely there's no point taking it. So if you want to take a collagen supplement, the preparation is key. We want a I completely cannot say the word. It's where the collagen is broken down into really, really, really small parts and it's easily absorbed. This is going to be better. Then also we have to have the big elephant in the room of collagen isn't one thing. We have over 6 types of collagen. So are you looking for collagen to help hair or eyes or teeth, general bone matrix, or your ligaments and your other soft connective tissues? So we're going to be looking at animal products because we do not actually have a really good, despite what marketing says out there on adverts, we do not have a non-plant-based collagen supplement because it's just not found in plants. So we want chicken, beef, fish, even eggshell membrane to come together. But actually, if we don't have the cofactors that help our body use collagen peptides, it's not going to make a difference to our EDS population. So those cofactors, vitamin C is the biggest cofactor. It helps us to use our collagen matrix structures. So as a really good real life sort of example of collagen supplementation, yes, I actually do use it in clinic for some people. For some people that due to gastrointestinal difficulties, they're not actually consuming a wide range of animal-based products, or maybe they're on very small, more liquidy diets. And we just want to make sure that they're actually getting the amino acids into their diet. I might use a mixed powder that's got all the different 6 types from the sources I just noted. And we're going to use it short term until we build up dietary intake. And then we're going to move away from collagen supplementation, and we're going to ensure that they have all the wonderful B vitamins and vitamin C in abundance to help the body. So I'm going to put collagen supplementation in a complete myth for EDS, but have a nod to it can be helpful for some people. And the reason, interestingly, why a lot of people say, I've been taking collagen supplement and my skin looks great, is because if you read the ingredients, it's also bound with B vitamins and a few other trace elements, and this is going to be helping. And also some people say, I felt better, I've had more energy, and that's because it's bound with B vitamins. So it's important when you look at these supplements to look at the ingredients and see what else is in there and what that might be doing for you. So not enough literature. We actually don't have really robust clinical observations either. So some of our work is clinically informed, and I don't see improvements in people taking collagen. But saying that, unless you're taking a lot and it's having a laxative effect, it's not unsafe. So if someone feels comfortable and they feel like they're doing something for themselves and they have money to spend on these supplements, as long as you're not foregoing a food first approach, it's not instead of eating good foods, it's not going to have a detrimental effect on you. It's just unlikely to actually help our collagen in the EDS world.
Wow, fascinating. Thank you. As I say, it's just so, there's just so many intricacies that you have to think about, isn't it, with nutrition? And it always fascinates me, you know, you're putting things in people's bodies, right? And in a very simple term, what, you know, food, supplements, it's going into the body. So it's going to have such impact, isn't it, on people differently. It's important that we get it right.
Yeah, absolutely.
And what about and what would this even mean? I should eat clean. Should I be eating clean? What is that?
Oh, Jeannie, this is one that makes me shudder. Or you just flick through magazines and clean eating. Oh, it's a real buzzword. And it's a buzzword that sells products because everyone feels, and this is outside EDS as well, everyone feels that they should eat clean. Well, clean is not defined like eat clean. What kind of like media marketing is putting on that is that it's often free from your general allergens, which are labeled allergens, which actually might not be. So it's probably gluten free, it's probably dairy free. And they're saying it's clean because it doesn't have sort of a lot of preservatives and emulsifiers, etc., etc. And people are restricting their dietary intake to have a clean food. So I actually have it in clinic actually. And again, no judgment on patients that come and they sort of very excited to tell me what they're eating. And actually some people are very proud that I eat clean. And it's that they're not having colorings. They're having maybe basic lean meats and whole foods, and they're foregoing all the other things. So they, you know, have kind of brought into this aspect of you have to eat clean for your body, like my body is a temple. That's just not how the body works anyway. We have a really good digestive system. We have fantastic liver and kidneys, and our skin is also helps waste byproducts to exit the body. So we can actually have some, unless you've got mast cell activation syndrome, of course, we have got tolerance to sugars, to emulsifiers that are approved for dietary human intake. We do have tolerance to additives and flavorings and things like this. And actually, sometimes when you are trying to eat really clean, what you're doing is depriving the body, and you can actually fall into nutrient deficiencies quite easily. So people say, oh, you should eat clean for EDS. This has zero meaning. There's absolutely no validated definition of eat clean, and there's absolutely no robust either scientific literature evidence, studies, or clinical observations of eating clean helps. But what we do know in nutrition science across the board is that if we have ultra processed foods, so as close to our food structure from whole foods as possible. And, you know, we try to limit artificial flavors and colorings, then this is better for general health. So this is very well understood. But the thing of clean, no. And also, I know this is a long answer, Jeannie, but I take issue with people saying you should eat this way for EDS, full stop, because everyone's so different. And sometimes someone's sense of security, feeling that they're following a clean diet, is actually bound up in quite a lot of fear of food and food hesitancy, which we have to acknowledge and have space for, and maybe have a kind conversation around of like, why is this built into your philosophy of eating, and what support might you need there?
Yeah, that's a really, really important point. Yeah, totally agree. There's too many shoulds out there, right? And with EDS, I don't think there can be any shoulds. Same goes with movement therapy. You know, there are no shoulds because everyone I see is so different. And so, yeah, making people feel bad about doing stuff or not doing stuff, I don't think is the way to go. Absolutely. Okay, lovely. Now I've got just a couple more, if that's all right. So let me see. Okay, so here's one where I might pronounce the word wrong, so please bear with me, everyone. Do I need to cut out oh, I knew I was going to say it. Oh, help me out, Lorna. Salicylates? Salicylates. No, that's wrong. Oxylates. See, I'm not, you can tell everyone I'm not a nutritionist or a dietitian. And histamine. Now, I do know histamine. There we go. So do I need to cut out those three things to control my MCAS? Now, I do have MCAS myself. And when I was diagnosed with MCAS, I was put on a low histamine diet, which was very restrictive, actually. So anyway, do we need to be cutting out these three things? Should we be cutting all of them out, or are we saying that some of them? I don't know what those first two are. Could you explain what those are?
And Jeannie, I'm a nutritionist and I have problems pronouncing lots of nutrition things. So salicylates and oxalates are bounded around, actually out of like the clean eating camp and the ultra strict sort of mast cell disorder camp of you need to exit them from the diet. So let's break down what they are, because there's actually a lot of misunderstanding of what these compounds are. And if you go on to any kind of social media platform, you can find even a qualified nutrition professional telling you, or a functional medicine doctor telling you, you need to remove these. So it's really hard for someone at home that's not scientifically or nutritionally qualified or savvy to break that down, because actually it's like that yellow brick road. It's full of hope and it's like, oh, I should be doing this. Salicylates are a really interesting compound. They're a bioactive organic compound that's found in food. So it's dietary salicylates, which come from salicylic acid. Also found in medication. So some of your anti-inflammatories, and also aspirin is high in salicylates. So a dietary source of salicylates is going to be 10 to around 200 milligrams, depending what you eat. Always found in plant-based foods, fruits, vegetables, spices, a lot of the common foods we generally eat on a Western diet. In medications, you're looking at 300 plus milligrams. So quite often people will come to clinic and say, I have to cut out salicylates because I've either read it, I believe it, or I have been diagnosed with mast cell issues. But when we have an evaluation, they have zero problem taking aspirin. So then we have to question medically, would a doctor diagnose someone as a salicylate intolerance or allergy? And this is very important for people to understand. Sometimes literature and findings in research gets translated in a very discombobulated way into social media, and actually it comes out with inaccurate information. Yes, some people are sensitive to salicylates, and this needs to be clinically managed. But actually, unless you have a really, really strict assessment from a clinician or a really detailed elimination diet and then reintroduce to really find out if salicylates are an issue for you. You won't know. And when people say I need to cut out salicylates, you're actually cutting out huge food groups. So you're running the risk of being nutrient deficient in literally all the nutrients and plant-based proteins, amino acids, and a lot of your fibers. Where the interesting thing comes is that people may say take salicylates out because it will reduce your pain and inflammation, but actually salicylates are found to help the body with pain and inflammation. So that's a bit of an oxymoron that I take issue with when people say you need to cut them out. If you were to have a problem with salicylates, what you're going to be experiencing is likely very, very high degree of nausea, hives on the skin, tissue swelling in parts of the body, pain in your abdomen, and diarrhea. So this would be clinically our signs of salicylate problems. So we might then want to, let's say, take some salicylate foods out, see how you go, and then reintroduce slowly. Quite often it's literally you've become insensitive because of poor gastrointestinal function. So this feeds into where mast cells sit, being a sort of inflammatory immune process. Just to give people an idea of the foods, sorry, it's quite a long answer, isn't it? But fruits, it's prunes, raisins, blackberries, these kind of fruits, and then red wines, of course. But if you do have mast cell problems, quite likely you're not going to be tolerating alcohol, not consuming red wines. Spices, now this is interesting because I've had quite a lot of people come saying, I've cut out salicylates because I've read online, and for my pain and inflammation, I'm having a lot of turmeric lattes. Well, turmeric is actually one of the richest sources of salicylates in your dietary salicylates. So paprika, turmeric, cinnamon, ginger, these are all very rich in salicylate natural compounds. Vegetables, we've got broccoli, chicory, radish, watercress, alfalfa, all these lovely sort of green foods. So where salicylates sit, some people with mast cell activation might improve reducing them, but there's not a broad stroke. So I would put that in the myth bucket, where salicylates, and actually very, very misunderstood of what salicylates are. And actually they're very important for the body if we consume them in our food matrix. So oxalates. Oxalates get such a bad rap, and it really confuses me why we've ended up with this situation of people saying you have to cut oxalates out of the diet. Again, it's a natural organic compound found in food, many foods, so many fruits, nuts, vegetables, etc. Where this myth, I think, has come from is that if you look at literature, it can be translated that there's a risk of having kidney stones or inflammatory problems from high consumption of oxalates. But this is if you naturally have a predisposition to urinary oxalate stone formation in the kidneys. So if I was to have someone in clinic and maybe that they've already told me that they've got some history of oxalate kidney stones, I'd be wanting to make sure they don't have kidney disease, and if they do, pass them to a renal dietitian. And we might want to make sure that we are having enough water to help break down those urinary oxalates, but we don't necessarily jump to removing oxalates. And I think where the myth comes from is that naturally oxalates are going to bind to our calcium. So quite often people will say, oh, you've got a low calcium blood test. That's because you have a lot of high oxalate type foods, which is nuts, fruits, seeds, etc. So you need to take out the oxalates so that we don't have our low calcium, but that's just not how it works in the body. It's a lot more nuanced, and a lot more clinical assessment needs to go on there. So I don't want people to remove oxalates unless they have a problem. Where that sits with mast cell is mast cells so difficult to manage, and it's so individual. You need clinical, a doctor to maybe assess what type of histamine blocker, H1 or H2 you need. So you need medication. And then we need to really get a good nutrition assessment of what foods are your problems and your triggers, and then we work from there. So the blanket removal of salicylates and oxalates, no, total myth. a little bit of misconfusion of what they are and how the body works with them dietary. And when I look at some social media posts with these gorgeous protocols of do my plan, and first of all we remove gluten, oxalates, salicylates, histamine rich foods, and what on earth have you got left to eat? And it makes my heart sink for people. So this again goes in the camp of if people have reduced oxalate and salicylate foods, it might not actually be that compound, it might be reducing processed foods. And if you naturally have found that you have improved reducing these foods, we want you to have a clinical assessment or at least a discussion with a medical professional why this is. And we want to absolutely make sure you're not going to have nutrient deficiencies as a result of excluding, because it's a lot of food groups. And we must remember salicylates and oxalates are bound to nearly all plant foods if we combine them. And we know that plant-based foods, for their fibre and their micronutrients, is where increased health outcomes are. So for better health outcomes for EDS, we're wanting you to have more fruits and vegetables. So it's an oxymoron to say cut out the two compounds that are found in its highest source. If that makes sense, that's quite a long answer, but actually a short explanation of what they are. So I hope that helps.
That was brilliant. Yeah, really, really good. Again, you're all listening to you, Lorna. I'm just thinking, wow, this is so complex, right? If I want to make any dietary changes, I have got to go and see a registered nutritionist, dietitian. You can't do this stuff off social media, I don't think. You can't do a post and change your life and look at the potential issues that you have with the wrong inputs, the wrong foods, taking out the foods. It's a huge topic, and you clearly have a wealth of knowledge. So thank you so much for sharing it with us. I mean, I keep saying this word because it's like mind-blowing. There's so complex. Now I do have one question. This relates to, actually, I've got a couple of questions around pots. Is it a myth that we need to have around 6 grams of extra salt? I don't know if that's a day for pots. So should I have more salt?
Yeah. So this is very interesting. And I have so many conversations with patients that I've got the diagnosis of POTS. So we make sure that we frame the understanding that POTS is postural orthostatic tachycardia syndrome. And it's a form of dysautonomia. And actually people with EDS, whether it's subtype or hypermobile or HSD, quite often have an umbrella dysautonomia diagnosis. Not everyone is POTS. So to examine whether this is a myth or not, when we look at POTS scientific literature in dietetics or nutrition science, it's absolutely where literature sits. So nice guidelines around the world, the consensus is that a dietary management for a person diagnosed with POTS is 6 grams of salt daily plus. So actually some people might go up to 12 grams of salt. Where the confusion comes in our EDS population is the causality of the POTS symptoms and also the other comorbidities. So, for example, someone might be neurodivergent and dislike the taste of salt. So we're not going to be saying a nutritional intervention is increasing your dietary salt. We're going to be asking a doctor to prescribe salt tablets. Also, where the literature that gives the guidelines of 6 grams of salt a day, which then translates into the sodium content. This is, people with POTS have it for viral reasons, other disease manifestations. And so it's a huge topic. For our EDS population, what we want to look at is, what else have you been eating? Because what I find clinically is someone may have a diagnosis of POTS and is told in their medical teams, you need an extra 6 grams of salt, but no one's asking what they're already having. And it might actually be that someone's already having in excess of that, but they aren't combining that with adequate hydration or potassium. So it's not all about salt for our EDS population, and it's It's got to be bound up with what are you already eating, what's your gastrointestinal function like, and what's your fluid intake like as a base. Some people just need to increase better quality of water with electrolytes because we need some glucose molecules and potassium to increase our blood volume. So it's not a myth, it is robustly in there with nutrition science, but it doesn't necessarily translate that clear cut as everything with our EDS population.
Great, thank you. So yes, definitely needing medical supervision then for or dietary guidance if we're doing that, rather than self-administering, I mean.
Yeah, definitely.
Okay. And you mentioned hydration, because there's also this myth that we should be drinking at least a litre of water as soon as we wake up. That seems an awful lot of water as soon as we wake up.
It is an awful lot of water. And again, this is not a myth. It is robust literature, sort of evidence that we have for people with POTS. So the research is POTS. The research is not hypermobile type and POTS or dysautonomia. So the point of having the litre of water on waking is it's going to increase blood volume, ready for you to exit your bed and stand up and get on with your day without feeling faint or falling over. The difficulties when it comes to EDS is if you have slow motility or gastroparesis or swallowing issues, a litre on waking is not realistic and often not safe. I am not going to want someone with any kind of a swallow issue to be having to feel that they need to drink a litre of water, because this is potentially going to be unsafe for them. If you've got gastroparesis, you're going to feel very uncomfortable quite quickly with a litre of water. And also, we know that many people with hypermobility and EDS subtypes have bladder complications. So I don't want you to drink a litre of water if you're then going to be really uncomfortable from a bladder point of view and have such urgency to go to the bathroom. We have to factor in safety of getting to the bathroom. We don't want you to rush. Obviously, in your movement space, you're going to be wanting to make sure people are safe from all levels of that front. So where the kind of, it does straddle into a myth of you have to have a litre of water, although it is in robust literature, it's slightly again misunderstood in our EDS population. So what we want to look at is overall dietary electrolytes and hydration over the course of the day, so that maybe we're supporting you better than having to have that litre of water in the morning. It is a lot of water to consume. And again, clinically, we want to assess you and give you some good strategies for that.
Perfect. Thank you. Okay, I have one final question or myth. Again, I've heard this quite a lot, that we should be following an anti-inflammatory diet. And I guess my question is, what would that be? What is an anti-inflammatory diet that we should be following, if that's true?
This is a good one to raise and to end with, because I hear it a lot as well. And, you know, I use the inverted commas anti-inflammatory diet. No one knows what that means. It's not even really robustly understood in nutrition science. What it means is that your food you're eating, so your dietary pattern, is going to aid the body to support the inflammatory processes. So you're going to be sort of helping the body not get so inflamed and to excrete your inflammatory metabolites through urine, poo and sweat. So it's a bit of an elephant in the room to say someone has to have an anti-inflammatory diet, because inflammation is huge. Where's the inflammation coming from? So a lot of the literature does suggest anti-inflammatory diet. It's from sort of more the joint MSK inflammatory processes, rheumatoid arthritis, for example. What that looks like is we know certain dietary rich compounds like your omega fatty acids coming from oily fish, which you can supplement as well if need. Magnesium, vitamin C, CoQ10, these are all anti-inflammatory compounds found in food that the body will use quite well to just reduce down. Same as turmeric is also used. but we have to really assess what's driving the inflammation in the first place. So it's not all about follow an anti-inflammatory diet to reduce your inflammation. And also people are very, and again, I say this with judgment of, it's not like, oh, you don't understand this, you're silly. Many things I don't understand if they're not in my professional world, but inflammation can be protective. So we don't always want to jump to think we have to reduce the inflammation. It's actually a biochemical process that the body needs. So it's, what are we talking about? So a good example is gut inflammatory processes. And this actually, if you have a sort of a medical inflammatory problem in, say, the colon, then you might have Crohn's disease. So we have to make sure that inflammation is being understood. And you know, if you go to the doctor, you might have elevated CRP, which is C-reactive protein, and some of your other blood markers from a medical point of view might be elevated or reduced. That would give clues to inflammatory processes being there. So where it comes to inflammatory diet, there's no blanket, there's no real explanation in this myth of what is it targeting, you know, what is it going to be supporting. So generally, when we talk about people wanting to help the body with inflammatory processes, from my side in clinical nutrition, I'm looking at your liver, because the liver is the sort of god of inflammatory processes and exiting waste product. So we're wanting all of our, what comes under the Mediterranean diet, our lovely whole foods, whole grains, lean meats, lots of lovely oils. So it's a plethora of food types. So it's a myth in a way, but again, it comes under the not quite well understood banner.
Yeah. Oh, fascinating. Thank you. Thank you so much. Wow. So I hope you enjoyed that. I feel like I've learned so much. And hopefully, you know, we've dispelled maybe some of the myths that are around regarding nutrition and diet, cleared up some of those misunderstandings. And clearly, from what Lorna's been saying, it's not just a simple black or white, yes or no. All of these things, the gluten, the collagen, all of those things, it's very complex. It's not just cut it out or add it in. So I'm really, really grateful for you explaining all of that so well, in easy to understand terms as well, for us non-nutritionists and dietitians. So if you have any questions or comments, please do leave them in the comments below, and I can get Lorna to answer those and we can get back to you. And I really think, again, really grateful for your expertise, Lorna, and I think so important. I just want to reiterate that please do consult with somebody who's registered, who's qualified, and has expertise. As you can hear from what we've been learning today, EDS, POTS, MCAS is very complex. Not everyone's the same. So please do make sure you're speaking to someone or consulting with someone who does have that specific expertise. I think that's so important. As I said, because we are putting stuff in our bodies and you don't know what reaction that's going to have. So I really want everyone to make sure they're getting the right advice and guidance. So yeah, thank you so much for watching. Thank you again to Lorna. Really appreciate your time. And please join me again for another episode of Myths, Misconceptions and Misunderstandings about EDS and HSD. And I will see you again soon.
Thank you, Jeannie.
Thank you, Lorna. Bye, everyone. See you soon.